I'd like to welcome Dr. Carlin Center, primary care sports medicine doctor with special interests in exercise counseling and prescription, as well as treating sports concussions. She is the director of primary care sports medicine and the co-director of UCSF Sports Concussion Program. Dr. Center earned her medical degree from David Geffen School of Medicine at UCLA with an internal medicine residency at the University of Washington and a fellowship in primary care sports medicine at UCLA. So she's going to be the leadoff hitter today. Dr. Center.
Thank you. Thanks.
You're all set.
All right. Good morning. Thank you so much. It's great to be here. Thanks to the conference organizers, Rhonda and Selena, and the committee for inviting me to speak. I'm Carlin Center. I direct our group of primary care sports medicine doctors, and am happy to be here to talk to you about sports medicine considerations for women and girls. I have no disclosures, and wanted to introduce you to some of the team of us that about a year ago started the UCSF Women's Sports Medicine Center. The QR code is here. We are super excited to kind of have a sports medicine focus for women and girls at UCSF, and please share this with friends, family, patients, if it's relevant. At the end of this talk, you'll be able to list 3 screening questions to ask all girls and women presenting for a pre-participation physical evaluation. List labs to order when evaluating secondary amenorrhea. Define relative energy deficiency in sport or REDS. List indications for a DEXA scan in an athlete. And identify factors that would make an athlete with REDS high risk for injury or illness if returning to sport without treatment. All right, so we'll start with a case. This is an 18-year-old female high school rower who presents for her PPE. You're reviewing her form that she filled out. She has a history of a rib stress fracture at age 16. She has not had a menstrual period in 6 months, and she worries about her weight. She tells you that she restricts her eating during spring season to make the lightweight boat. All right, so if you're not already using the PPE form when you talk to your athletes and do their annual physical exam, I'd highly encourage it. To me, this really helps me make sure I'm being comprehensive and complete. The PPE, as you probably know, starts out with a mental health screen with the PHQ-4. It asks about sports restriction, which I think is a super high yield question for any of our athletes. And then particularly relevant for our female athletes are 3 questions. One, have you ever had a stress fracture? You know, super relevant, good to dive into that question with folks. The next ones I really like are the questions about body weight, because I think I find that athletes are pretty honest and find these questions pretty approachable. So question 25 is, do you worry about your weight? Question 26 is, are you trying or has anyone recommended that you gain or lose weight? And I don't know about you, but year after year, I'm always surprised by how many athletes, boys and girls, will actually indicate, yes, someone has told them, has given them input about their body weight relevant to their sport. So I think that's always a question that clues me in to sort of check in about that, ask a follow-up question. Usually what I'll say is, tell me more about this. Could you share with me more about this? And, find out a little bit more about what's going on. And I also then will ask them, okay, so someone has suggested that you should gain weight or lose weight, like, what are you doing with that information? And what kinds of things are you doing? Exploring things like their diet, of course, supplements, drug use, and so on. And then the last section are menstrual questions. So also a real quick way to just screen for amenorrhea. And of course, young people can have irregular periods. We know that, but making sure that they haven't missed a period for 3 months or more. Anyone who has missed a period for 3 months or more really should have some follow-up questions about that. Okay, so this is to get us rolling, kind of get your minds going. I wanted to ask everyone in the audience, when you think of an athlete who has not gotten her menstrual period and who has a history of a bone stress injury, in this patient's case, a rib stress fracture, what might cause this? What kinds of problems would cause this? So I'll invite you to just yell it out. What's on your mind? Like, what are possible things? Reds, yes, red S. Could be red S. What else? I couldn't hear you. Good morning. Yes, good morning. Yes, we're just revving up.
Well, I'm thinking, there's low bone density, so you've got not enough estrogen to help with
Yeah.
bone.
Yeah, with bone strength. So
growth and-
exactly, we know bone density relies on estrogen. Most obviously in a postmenopausal woman where estrogen drops, you develop osteoporosis. So in a young person, that can also happen. You can have low estrogen, and there's a variety of causes for low estrogen in premenopausal women and girls. So we're thinking hormone things, we're thinking REDS, which is really a fueling and energy availability thing. There's a list, so a list of endocrine problems, thyroid disease, ovarian insufficiency, so the ovaries are not pumping out hormones, hypothalamic dysfunction, of which functional hypothalamic amenorrhea is the term for the problem that's happening in REDS. The risk factors for that are weight loss, excessive exercise, stress, severe or prolonged illness. Interestingly, traumatic brain injury also can cause hormone issues and secondary amenorrhea. Pituitary dysfunction, such as someone who's producing too much prolactin or someone who has Cushing disease, too much cortisol, polycystic ovarian syndrome, and then of course, pregnancy would cause you to not have a period. Always good to remember. So in our evaluation, first we start off by ruling out pregnancy with an HCG, and then ordering FSH, estradiol, a TSH for thyroid, a prolactin, and then if your patient is demonstrating hyperandrogenism, to think about getting a testosterone. And then I'll usually add some additional labs if the patient's had a bone stress injury. So bone stress injuries and restrictive eating is associated with iron deficiency, so I'll usually screen for iron deficiency. And then I'll usually also get a vitamin D and a calcium and an albumin just to correct the vitamin D, to correct the calcium. All right, so a busy slide, which is honestly a little hard for me to read even on this screen, but this walks us through how we interpret these labs. So I'll just talk about what we most commonly see in sports clinic and in primary care clinic in a setting like this, with someone who's a young person who's otherwise healthy, who is very physically active and has had a stress injury. So in her case, her prolactin would be normal. She doesn't have a prolactinoma. Her TSH would be normal. She does not have thyroid disease. Her FSH, so the question is her FSH high or not? And in her case, her FSH would not be high. It would either be low or normal. And so then you look at estradiol, and you say, okay, well, what's going on with the estrogen? And in her case, her estrogen would be low. And so that low or normal FSH and low estrogen means she falls into that functional hypothalamic amenorrhea group. Now, that's not the only thing this could be. It could still be a problem with her pituitary. And so sometimes we will still get a pituitary MRI to rule out a mass. But in many cases, this is functional hypothalamic amenorrhea. In your handout, you can see, the sort of cascade of events. If the labs don't end up that way, there are other things to think about. But in this case, this would be an example of functional hypothalamic amenorrhea due to low energy availability. And what happens is the body really just suppresses our physiologic function to prevent pregnancy and to avoid more energy drain. This is a diagnosis of exclusion. And what's happening is decreased GnRH leads to decreased LH and FSH and then decreased estrogen. What's recommended is if one is not used to treating this, to consult with an endocrinologist. So this really brings us to the whole concept of REDS, which was mentioned right off the top as one of the causes of secondary amenorrhea and bone stress injuries. So REDS, so relative energy deficiency in sport, this used to be called female athlete triad. It's evolved to be called REDS. And what this is sort of the central idea that low energy availability leads to physiologic function problems and impaired psychological function. And the key to REDS is this concept of low energy availability. The clues to look out for in our student athletes, first is BMI. So BMI is not a perfect measure, but it is a measure of body composition. And so folks who are high risk for REDS would have a BMI under 17.5, or they would be under 85% of expected body weight when they're in adolescence. Moderate risk would be slightly higher, so BMI under 18.5. If you're meeting with someone and they have had recent weight loss, or if they endorse disordered eating during their PPE, I think that you'd want to screen further for REDS. And then importantly, the consensus statement on REDS really emphasized that if you're meeting with an athlete and they have a low body weight, but they're like, well, I'm not losing weight, I'm fine. A low body weight but that is stable should not be interpreted as ruling out normal energy balance or ruling out low energy availability. You can have low energy availability and not be losing weight. It's just that your physiological function and perhaps your psychological function is being compromised. So you may not be at your optimal weight, and you may have impaired function and impaired athletic performance if you're trying to compete and train below your healthy body weight. The definition of low energy availability is when our dietary energy intake minus the energy we expend in exercise is less than the body's energy needs. So basically, you need more energy than you're putting in. It can be mild and transient, which is benign and called adaptable LEA, or it can cause health impairments and lead to decreased athletic performance, which is called problematic LEA, and these things are on a spectrum, from benign to adaptable to problematic. Also, and interestingly, there's this growing body of literature about low carbohydrate energy availability. So it's thought to be that there can be athletes who have, they may look like their energy availability is okay, but actually their macronutrients are all messed up because, we're very interested in protein. And so sometimes we eat a lot of protein and then just no carbs. And there's actually some literature showing that some athletes suffer from low carbohydrate availability specifically. So if you're seeing an athlete and it's kind of like, gosh, it seems like everything's checking out, they're fueling, well, look at the macronutrients as well and think, okay, maybe it's a carb problem specifically. One challenge about REDS and energy availability is how hard it is to measure. So it's very challenging. It takes a lot of time and effort to measure, to figure out if someone's in energy balance. It's difficult to be accurate. It involves measuring body composition, which needs to be done in a sensitive manner and should be confidential and really only shared with people outside of the athlete's family if the athlete consents to that. Historically, it was published that the definition of low energy availability was under 30 kcals per kilogram of fat-free mass per day. That was thought to lead to health problems, but when that was published, it really wasn't intended to be a definition. It was sort of more of a research thing. And so it's been shown over time that this really varies. It's very individual. It differs by people's sexes, and it's variable. So I think this is really an area of evolution in the science of REDS. I also wanted to share this paper with you. This is a paper that came out after the consensus paper on REDS. And these authors really propose kind of an alternative explanation for when athletes come into us with these concerns. So an athlete comes in saying, you know what, I'm just not recovering. I'm just feeling worn out and tired, and I'm not performing well. Is it always about energy availability? And these authors say, you know what, we should take a more holistic approach. You know, this could be about sleep problems. This could be a primary mental health challenge. This could be an infectious disease like mono or long COVID. So, you know, I think this paper reminds us to keep the differential broad when we're, you know, if we're starting with an athlete who has amenorrhea and fatigue and maybe some gastrointestinal problems and some sadness, you know, to start as we do with a whole patient approach and approach that holistically. This is the REDS health model. And so in REDS, you see on this graphic that low energy availability is the hub. And then there are these downstream physiologic problems that are due to this root cause of low energy availability. That's the hypothesis in REDS. And so talking to a student athlete about, well, you know, I think that the fatigue, the GI issues, the stress fractures, and so on could all be due to this low energy availability. And then if someone's not hearing us, or maybe they need a kind of different message, you can also talk to them about performance. And so the consensus group also presented this graphic where really low energy availability leads to all kinds of performance challenges. Trouble with recovery, trouble with you know, strength and speed and so on. So depending on the person, they may hear us when we talk to them about the health challenges, or they may hear us better if we put that in terms of how this is going to affect their athletic performance. And when we think about a patient with these kinds of presenting concerns, whether it's I'm not recovering, I'm really tired, I'm not getting the times that I'm used to getting, I've had these stress fractures and so on, I'm not getting my menstrual period. That could be REDS, it could be, you know, a number of other, you know, concerns not having to do with energy availability necessarily. It could be overtraining syndrome. It can be very tricky to sort that out. The main thing, the main way to kind of rule out REDS is to prove that they are in proper energy balance. So to say, okay, yeah, it seems like they're getting enough energy. And if you've ruled everything else out, there's not an infectious disease, mental health is okay, you know, and so on, you then arrive at a diagnosis of overtraining syndrome. So overtraining syndrome is really like the final thing once you've ruled out REDS. But very challenging, all of it, because there aren't great measurements. There's neither REDS nor overtraining has like a great lab marker or something where it's a slam dunk diagnosis. A note about REDS in para-athletes. So there's concern that para-athletes may be higher risk for low energy availability than able-bodied athletes. This was shown in a recent study on US Paralympians, where 62% reported to changing their weight or body composition to enhance performance. 32% had increased scores on an eating disorder questionnaire, and 44% of the female athletes reported menstrual dysfunction. All right, so thinking back to our case, we have our 18-year-old high school rower. She has amenorrhea, she has a history of a rib stress fracture. Her BMI is 18. She has some restrictive eating. She does not meet DSM-5 criteria for an eating disorder. She had menarche at age 13. Her labs are consistent with functional hypothalamic amenorrhea, and her DEXA has a Z-score of -1. All right, so a lot of information. I thought we would all take a minute to digest this case and turn to your neighbor and talk about, would you clear this athlete to row? So I'm going to give you 60 seconds, and then I'll ask you to report back.
Sorry, we're just doing a quick stress test on this guy. There you go.
right, I'm going to call you back. Thank you. That was great, great conversations. I'm interested to hear about people's thoughts. Would anyone be open to sharing a little bit about your conversation? Please.
So we discussed in our group that you had mentioned she hadn't had a period for 6 months. And with this diagnosis, they mentioned if you're not comfortable managing this, trying to discuss with the
Yeah.
So that is what I've been
Yeah. Yeah.
going with. And obviously, if she does buy in to the thought about cutting back on exercise and increasing her nutritional intake, and potentially if we see she gets a menstrual period, say 2 or 3 months in a row, that'll be like a green light to say, okay, we are making some progress, and then we can review. Is this for? I mean, how long did that take? We actually did an extra scan at some point. We didn't really have a consensus.
Yeah. Yeah.
Kind of what we had to talk about.
Thank you. Thank you. Yes.
We want a little bit more information. She's 18, she's a high school rower, and she's trying to get like a scholarship to row, because I feel like that also pertains to how you would approach it. And then also just, I'm kind of thinking out loud, like the fact that she's a rower versus a different sport. I think if she was playing more contact sport, I'd be more concerned with this sport.
Yeah. She were like colliding with people, like, yeah.
With rowing, there's no, like it's still random, but it's not like super.
Yeah, you're not worried she's gonna like break her femur by being tackled or something.
But it also depends on her position in the boat.
Is she in the engine part? She's the one driving that boat? Or is she a coxswain? You know, because then she's just sitting.
Fair, yeah. So,
No, I mean.
yeah, is she a coxswain or is she a rower? Where is she sitting in the boat? Yeah, there you go.
Right, so, and I think it can be motivating along with what, is it, sorry, almost. Along with what Eze was saying, I think you can hold her and not have her participate until she can show that she's having a period again, and all of that, but that can be motivating for her. Because it's like saying, you have to hit these criteria before you can continue with this safely, right? And it does matter whether she has to, you know, she's trying to get into college or do something like that, but they can also know that, you know, and go, okay, you have a year to get this together and we'll still.
Timeline and
Yeah.
gives you a real good sense of what kinds of pressure she's
Right.
under,
Right.
what's her timeline like. Yeah.
This is more of a question for the group. So what if this is an athlete who says, yeah, my college scholarship depends on me rowing this season,
Yeah.
and if I do not row, I can't go to college. So you're basically, if you do not let me row, you are basically ruining my entire future, right? Because patients will say that to you.
Yeah.
Yeah. So does that change your algorithm or your thought process?
But if you say you clear her to row, and she ends up with all kinds of stress fractures, then can she still go to college and continue rowing, because that's why she's there apparently? So you know, I mean, that's what she's risking.
Especially if it's a recent stress fracture.
Right.
It's
And
not ideal.
like depending on her position in the boat. So
If you don't clear her, she'll also just go to a different, she'll find a way.
she might. She might.
If her goal is, if she's going for like a collegiate athlete, like she worked her entire like high school career. That's what she's doing. That's her scholarship. I feel like it'd be better to clear her with like parameters and to talk with her and be like, okay, I'm gonna work with you like once a week, once every time. Let's do this systematically so that you can at least have an eye on her. And like follow her trajectory.
Yeah, it's like a harm reduction
Right.
model.
Yeah, no, that's a great idea too. Yeah.
Great, thank you.
As long as she knows that she's taking.
Yeah, it's a risk-benefit discussion, of course, and really trying to understand who is this person, what's motivating her, what's her timeline, what stresses is she under. There are published indications for DEXA in young people. So this was published by a group of sports medicine physicians in 2014, sort of if a person has high risk factors for low bone density, then getting a DEXA if they are greater than or equal to 2 moderate risk factors. And how do we interpret DEXA for young people? This is just a reminder. So if you're under 20, we should be scanning the whole body or the total body less the head in addition to the L-spine. If they're 20 or older, then it's femoral neck and L-spine. And in either case, for premenopausal girls or women, to use the Z-score, not the T-score. For postmenopausal women, we use a T-score. And the lowest score guides treatment. How do we interpret her DEXA? So what's the definition of low bone mineral density in a premenopausal woman? The published definition is a Z-score of less than -2, less than or equal to -2. However, the American College of Sports Medicine reminds us that we should expect that a female runner, someone who's doing high impact sports, should actually have a higher bone density than -2. So they encourage us to use -1, as was the case here. Osteoporosis is a Z-score of less than or equal to -2 and clinically significant fracture history. I find this framework to be really helpful, and this is in your syllabus as well for your reference. If, in case you come across a case like this, I just really like this tool, which allows you to kind of count up risk factors and risk stratify your patient to say, well, how risky is it for her to go back? How likely is she to get re-injured or get an illness? And this helps you go through these categories. All right, what's her dietary situation? What's her BMI? What's her menstrual period history? What's her bone mineral density? And what's her history of fracture? And so you can kind of come up with a score. In this athlete's case, her score is 5. And then there's another table in this paper that helps you decide, okay, what clearance am I going to do? And based on her risk score, she's a 5, so she's a moderate risk for having another injury or illness. And I think as you articulated, you would want to have a plan with this person. You might clear her provisionally to do some stuff, but it's not going to be just full steam ahead. She needs some treatment, or more evaluation and treatment. The REDS consensus presents this sort of green to red arrow as the same concept as really identifying risk factors for ongoing problems in a student athlete or a young person or anyone really facing REDS, and looking at primary indicators for REDS that are high risk. The more of these you have, the less likely you would be to clear the person to participate. Secondary indicators, so a little bit less concerning. You might clear this person, but keep an eye on them. And really, as was discussed, the treatment is to increase energy availability. Easier said than done for all of us who've taken care of folks in these situations. So to increase dietary intake, decrease exercise. This has been shown to restore the menstrual period. It has been shown to increase bone density. Often these patients benefit from a multidisciplinary approach, and this is a very gradual approach over months. In athletics, we often do have like a contract or an agreement with the athlete so that the expectations on all sides are super clear and the athlete understands what we're doing, what the timeline is, and what the expectations are for their participation, both in sport as well as in their healthcare. All right, that brings us to the end. So I told you that at the beginning of this talk, you'd be able to list 3 screening questions to ask all girls and women presenting for their PPE. So we talked about history of bone stress injuries, we talked about concerns about weight, and we talked about amenorrhea. We talked about labs to order when evaluating secondary amenorrhea, so remembering prolactin and thyroid, and then of course FSH and estradiol. We We talked about REDS and the definition being low energy availability, the indications for ADEXA in an athlete, mostly being high risk for bone stress injury, anything that contributes to that. And then injury factors that would make an athlete with REDS high risk for injury and illness, same idea, amenorrhea, eating disorders, stress fractures, and so on. And wanted to leave you with some resources, so I wanted to ask you to save the date. Our annual head-to-toe sports medicine conference, this is for physical therapists, athletic trainers, PCPs, will happen in San Francisco in December, this year, December 4, 5, 6 at the Hyatt Embarcadero. So wanted to invite everyone to attend. And if you're not already using our rehab website, please do share with friends and family if you're looking for like, hey, this is some rotator cuff rehab that will help you, or hey, here's an ankle sprain protocol. We have that posted for you online. We also have a big treasure trove of videos that we post after these courses. So if you are looking to refresh your knee exam or how to do a shoulder injection or anything of the sort, you can search for it here on our Ortho YouTube site. And we do have tutorials about injections and then podcasts as well. So I did a couple Curbsiders. Curbsiders is an internal medicine podcast, and I did a topic on shoulder and knee, and there's some great ortho topics as well, given by Ted Parks, who's an orthopedic surgeon and a great teacher. So if you're interested in listening to some ortho updates as you drive, tune in here. Oh, and there's a concussion one as well. So appreciate your participation and your attention. Thank you so much.
All right, thank you, Dr. Center. Next up, we have Mary Lesser. She's a dietitian providing comprehensive care for inpatient and outpatient and leads the Bay Area's only pediatric sports nutrition program. She earned her bachelor's degree from UC Davis and her master's in nutrition from Tufts University. And then she completed her dietetic internship at Tufts and then went back to UC Davis for her doctorate in nutritional biology. So welcome, Dr. Mary Lesser.
I just hope the formatting is okay.
So that's Carla.
Okay,
There you go.
perfect. Awesome. All right, good morning, everyone. Thank you for having me here today. I am super excited to speak, and I think it's a great transition. All of the information on REDS is something that's obviously very prevalent in my clinic, and the team here is amazing with the referrals to nutrition to rule out that energy deficiency part of it, where I get to do my full jump-in analysis. And so today's talk is actually going to be hopefully somewhat generalized, although I think we all know here that when we're working with athletes, patients, or what have you, it is really an individualized approach that we're taking. So hopefully with the information today, you can see that you can take the general and apply it into your own individual clinics or patients or whoever clients you might be working on. So my name is Mary Lesser. I am a sports nutrition dietitian here at Children's. I see athletes not only in Oakland, where technically my home base is, I actually see all athletes throughout the Bay Area. And oftentimes I do get referrals from different parts of the state, and which is pretty cool. I've actually worked with athletes from my hometown in Rockland. But in addition to my role at Children's, I'm a professor at UC Berkeley, so I do work with, not in the sports, not at Cal Athletics, but I work very closely with those dietitians and some of the research that they're doing up with their athletes too. So it's also kind of cool sometimes to have the athletes that I've worked with in my clinic who've gone on to college, particularly at Cal, and I know that they're working with those dietitians there as well. So nice continuum. So I have no conflicts of interest to disclose today, and our objectives for today's talk is that I really would love you all to take away, how to recognize the importance of nutrition intake as a whole, thinking about patterns and behaviors specific to the pediatric athlete, including in and outside of activity. So I know a lot of times when we're speaking about sports and athletics, we're thinking about how to fuel the athletics. And the unique thing about pediatrics is that we need to think about what's going on throughout the day, because there are other activities too that we need to keep in mind. And then the second objective for today is for me to propose some strategies and tips for young athletes with and without special dietary and nutrition needs in order to optimize their health as well as their performance in sport. So we're going to cover some basics around what my approach is in terms of how we assess an athlete in terms of their nutrition, how to generally set goals for sports and our sports athletic goals for our young athletes, propose the strategies for helping to meet those nutrition goals. I know Dr. Center talked about like how do we increase energy needs for Reds patients. It is very difficult, and sometimes it can be a very general like here's what we can do, and then sometimes it's like okay, I have 3 other kids that are in athletics, like what else can I do to also make sure that I'm meeting their needs as well? So it can be a deep dive. And then just to provide some take-home messages. So first up is assessing the athlete's nutrition. So there are 4 different components of this that are always consistent in terms of my assessment of my athletes as well as their sport. So I'm looking at dietary intake patterns inside and outside of the sport. And then I'm going to be taking a look at diet quality. And this is not just are they eating processed or unprocessed foods. This is looking at the whole picture of what they're eating, when they're eating, what types of foods, so I can get a picture of where their energy is coming from and if their micronutrients are being met as well. And then supplement use. This does come up, and not just in the terms of are they taking a vitamin or mineral supplement, but sometimes I do get some specific questions around should I be taking caffeine supplements? Should I be taking creatine? Like I watched this person on a podcast or listen to this person on a podcast or this person on a YouTube and they say I should be eating a raw diet but also taking these supplements. So that comes up as well and something to capture. All right, so dietary intake pattern outside of the sport. This is a lot of the questions that probably, if you are asking these in your own practice, no matter what field of healthcare that you're providing, is looking at the whole picture. When and where is eating occurring? Is it just in the house? Is it at school? Is it on the field? I have some athletes that are having to go into the city if they are doing intensive ballet. Are they eating on BART? Are they jumping into a carpool? Where is this eating taking place? And what's the pattern like? Are they packing their food? Are they picking up something quick? How much of the food is actually being consumed? This is a tough one. This is a tough one for dietitians as well, because we get a lot of like, well, I think I eat like half of this. Okay, well, what was the original quantity to begin with that you were eating, right? I usually take a couple bites and then I have to run onto the field. Okay, well, what is a couple bites? Like half a granola bar, like 2 small bites. So again, like really trying to get that snapshot. The types of foods being consumed, right? So is this a family that is on the go all the time? And so like they're like, we have to default to prepackaged food. So here are the things we get at Costco, here are the things we get at Target, Walmart, what have you. Or is this a family where like they're like, we make everything on Sunday night, we prepackage, have it out for the weekend? Or is it's kind of a mess every day? It just depends on what the schedule is and we're just tackling it as we come, right? So what types of foods are being consumed, when, how much? And then one other big one that I have to come up with or tackle in with my athletes is not only how is their energy level through their sport, because I will say 99% of the time, most athletes say, I feel great. I have so much energy. Like I feel like I can finish all of my practices. I felt great after my game, what have you. And then I start to peel back and say like, okay, well, what about, what about after your morning break? I was a little tired. Like I felt like I was a little like lethargic, or like, there's certain classes that I fall asleep at. And so then it's kind of digging like, well, is that a boring subject because we're all not as interested in it? Or is it that like, it's 1 or 2 o'clock, you didn't really get a chance to have something in the morning, you were up late staying up doing homework because you had a late practice, and that your lunch was only something small because you wanted to spend time with your friends, those are all very important things and have to come up. So again, taking a look at those energy levels throughout the day, not just at the athletics. All right, thinking about in and around your actual athletics. Are these athletes eating anything before they're going out to practice or train? To be honest, it's like 50-50. I have some athletes that are like, oh yeah, I definitely always make sure I have a snack. I have other athletes that are like, I am running from class to practice to get home, change. I have 30 minutes to do homework to go to the next thing. So really trying to take in like how much fuel is on board before they're going into their activity. Also, what is the activity? Because obviously if you're going in for a 2-hour practice as a soccer player where you're on the field moving for greater than 60 to 90 minutes of high intensity, there's going to be more need for that versus maybe a recreational athlete that has practiced for 30 minutes and they don't necessarily need as much because they might be working on strength training, so it's a different type of fueling. Typically the window that's recommended for eating before for pre-fueling activities is 1 to 4 hours. Oftentimes that is capturing not only do they have a snack, but did they have lunch as well. And sometimes I see the combination effect of like, I don't have time to have a snack, but I'll have a larger lunch and then I'll have something small for a snack. And that can all fit into that as well. Again, the type and quantity of the food consumed, because sometimes I get the complaints of like, well, I don't usually eat something because I have a stomach ache. Okay, well, what were you eating before and why might that be giving you a stomach ache? Was it a super heavy, like dense meal, like that was too large, knowing that you were going out to run? Or was it something that the makeup was a little too much, maybe too much fiber, protein, fat, or what have you, so it was taking longer for your body to digest because you were eating it 30 minutes before? And then always fluids. This is a hard one. Particularly I find for my high school athletes is making sure that not only do they have the water bottle, but they're actually drinking the water bottle. It's been a little bit easier since COVID when like water bottles were not okay, eating in class or drinking in class was not okay. So now it seems to be a little bit more flexible. So sometimes it's just finding out like if you're drinking, when you're drinking, and how much. And the types of fluids too. Unfortunately, I get athletes that are like, I don't drink anything all day, and then I slam 2 water bottles before practice, but I don't feel very good. And so it's like, okay, great. I love that you're recognizing that fluids are important, but like, how can we break this up throughout the day so that you're not going into practice feeling slushy? We don't like that. Also, I do get a lot of questions about what fluids are appropriate, especially as some of my athletes are getting into that transitioning to college or out on their own. Like they do enjoy, beverages that have caffeine. Is that okay? Not okay? Is that dehydrating? How much does that, impact their dehydration status? So there's a lot of conversations around that as well and the use for them. And then eating post-workout and events. So the timing, I get a lot about like, do I need to drink that chocolate milk as soon as I finish getting off the court for basketball practice? Or is it okay that I have dinner within an hour of being home? And so we go through that as well of like, when do you eat after your workouts and what types of foods you might be eating and how much? And I do take a look at, kind of the snapshot of, our macronutrients that we would want to have, macro being our energy providing nutrients, which we'll go into in a few slides about carbohydrates, proteins, and fats that are going to give us our energy. And then again, fluids, especially depending on the type of workout it was. Was it a really hot day? Do we have our soccer players or lacrosse players out here on this side of the tunnel where it's a lot more, hot, there's a lot of sweating. I'm personally a heavy sweater, I'm a runner, and have experienced dehydration in a way that I would not want anybody to experience, even when I was trying to hydrate properly. So all the things to practice and keep in mind. Another part of the nutrition assessment that comes up is injuries. And again, this is a general talk, so I'm kind of bringing up the bigger things that come up at my clinic. I do get quite a lot of referrals for athletes that have been injured. Maybe they've just started to return to sport. Maybe they haven't fully returned to sport, but really thinking about like where they're at and how to balance their nutrition, because nutrition is very important in the healing process, as well as hopefully to help prevent further injury. All right, so in general, kind of what happens as a reminder in the stages of healing, and again, this is a very broken down approach, is that you have immediately that inflammatory period, right? There's an injury, you've got all of our mediators, our body switching into like, let's pro-inflammation, we want to get to healing and such. Nutrition doesn't necessarily have a huge role in this first stage and part of the healing process, but there is a switch in how nutrients are used because we are prioritizing healing. So this is where you would see like the prioritizations of proteins being used to go into those healing mediators and such. So there is some changes in nutritional status, but not really in the sense of that we need to do any full nutrition intervention. It's when we start to get into the proliferation as well as the maturation stage that nutrition really comes into play, because we need to help support that healing process and to recover from that first inflammation. And again, this is also in the context of what the injury was and the time it's going to take for that injury to heal. So some injuries might be a twisted ankle or something, and like, yes, it is, you know, something that does take them out of their sport, but it might not take as long to heal that as like a, you know, a pretty severe like fracture, or even if they've had to have like a major surgery like an ACL tear or something where you see actual like decompensation of the muscle, and that there's going to be more involvement in that. All right, so I bring this up because when I get athletes, I get them to come in to work with me at all stages of healing. Sometimes it's something that happens right afterwards. Sometimes it's, you know, almost a year out of their surgery and they're still having some lingering problems and they're really just trying to maximize. So I have to take into consideration what they're doing, what the level of activity, and then as well as what I can help with supporting in terms of recommendations for their nutrition. Other considerations that most often come up in my clinic that I am assessing for. Food allergies are a big one. Food allergies not only in the athlete themselves, but sometimes if there's food allergies in the home, so certain foods and such need to be avoided, and how to work around building a dietary pattern that would help out with meeting needs still. Food intolerances, right? Lactose intolerance, certain wheat or gluten intolerances, and so we're having to avoid certain foods again to not trigger any flares. These are big, especially for someone maybe who's coming in with celiac disease and they've been hearing like, I need to have my carbohydrates, but most of my food that I'm being recommended has you know, wheat in it. That's a carbohydrate-rich foods. What can I do? I also bring this up because sometimes I have athletes that come in that are following specific diets for medical reasons, like they have Crohn's or ulcerative colitis, and they need to follow a specific diet, like the specific carbohydrate diet, or they're on exclusive enteral nutrition, but yet they're still an avid athlete. So it's again meeting those nutrition needs while also supporting what that medical nutrition therapy treatment would be for their medical condition. Vegetarian and vegan athletes, for sure. And I get a lot of, when I say vegetarian, vegan, it kind of runs the spectrum. It could be a vegetarian that's a lacto-ovo, only consuming milk and eggs, some that are consuming no meat or animal products at all. Again, all find a support in youth athletics. It's making sure that we're meeting all nutrition needs though, when we know that some of those kind of bigger food sources that we're more commonly we know or hear or seen or recommended are not going to be what we can recommend for these athletes. I will say it does help that I'm married to a vegetarian athlete, and so I have a lot of extra recipe ideas and such that I usually am sharing of like, I've got this for you. He's a endurance cyclist, so we have a lot of recipes. All right, so in thinking about the assessment, really it's a lot of information collecting at first. I can go back here. A lot of information collecting, so then I can start to build the picture around what does this athlete need based on their sport, based on their medical history, based on their GI history, based on what the referral was for, based on where they're at in their development. Because that's the key thing with pediatrics, which for anybody who I believe in this audience is working with, is that there's a lot of that extra special growth and development that's going on, that on top of whatever medically might be going on with your athlete, you are still trying to support that normal development that we would expect and hope for in these athletes. All right, so with all that information, I take all of that and piece it together. I do take a very detailed diet record from these athletes, and I run it through different programs to actually get a diet recall to give me an estimate of how much energy they're getting. And then I break down of where that energy is coming from, because again, depending on the sport, the energy you need to fuel that sport is slightly different. I also want to know, are they meeting their micronutrients, their vitamin and mineral needs, particularly if they are presenting with fractures, they're transitioning into that really big like bone growth phase, that we want to make sure that when they have that jump up in actual recommended need, that they're meeting that. The biggest one that I see is calcium and vitamin D. Calcium being when we transition up to, if I remember correctly, I think it's like 12, we jump up to 1,300 milligrams per day. And when I break that down to my athletes of what does that look like for food, because that's the other thing, we don't eat numbers, we don't eat nutrients, we eat food. That would be like 5 glasses of milk, like, because each 8-ounce glass of milk is 300 milligrams. Now granted, there are way other food sources besides milk, and we talk about that, especially because I have a lot of non-milk drinkers, but just to give them that perspective of like how we would translate that to like the food and what they could do. All right, so setting the goals, again, is going to be based off of that assessment. And some of these are obviously me-driven because I'm the dietitian, but a lot of them are actually really driven through the athlete and the family themselves. One of the first questions I ask is, why are you here and what do you hope to get out of this appointment with me? What can I help you with? And what's important to you? We do a lot of talk actually before I even get to the nutrition about the sport themselves. I just am interested in what the athlete wants to know, what they want to talk about, why they're interested in their sport, how long they've been a part of their sport, and like what they really want to do with their nutrition, because that helps me identify their motivation and helps me to do with goal setting with these athletes. So general goals that come up, and again, individualized depending on who you're working with, are identifying what the common challenges and concerns to that athlete as well as their sport is. Again, a ballerina who is, intensive doing point as well as, multiple days of training and they're traveling into the city because they're part of the San Francisco Ballet is very different than somebody who is playing, let's say, competitive soccer, right? Two different needs, although they could be playing competitive soccer both for high school as well as a competitive club team. But again, very different needs, very different energy availability, right? Also then meeting nutrient and energy needs, so separate energy coming from our energy providing nutrients, carbohydrates, protein, and fat, and the actual nutrient needs. And so there are specific recommendations, and that depends on the athlete themselves, right? So we have different age groups that have different needs based on what their development would be. We have different needs depending on the type of activity as well as if there's any sort of unique needs based on medical condition or a specific injury. Right, because we really want to make sure that we're meeting these needs with a variety of foods and fluids to, again, support that general health and development of our athletes. And then encouraging intake of food items with those nutrients to optimize performance, prevention, or recovery of injury. So really taking a look at if there are any, let's say, holes, or if there is areas of improvement. Most of the times it's areas of improvement. Most all athletes are eating, and they're eating okay, but there are ways that we can kind of tweak and help them kind of really enhance and meet those goals a little bit more. And then promoting age-appropriate independence and ownership of athlete sports nutrition goals. Right, so this is a big one, especially for my teenage athletes that are, again, looking to transition out to college. We want them to take ownership of this because that's also going to get their buy-in, right? But also because they're starting to think about, if I'm going to continue athletics, either at the collegiate level or competitive, even if it's just intramural sports and you're having a good time, or I'm going to keep with my club team, they're going to be doing this out on their own more often than not. So how can we get them more involved? Is it giving mom and dad what the list of foods they want to try this week? Is it having them kind of plan out when they need a pre-feeling that they have to pack it versus it'll be available to them because their team provides it for them, right? Getting an idea of if it's going to be a really long day because we have projects due in school or there's extracurricular activities with church and other clubs, planning out when you might be able to eat, right? They can be very basic or it can be very intense. Sometimes it's also just somebody who's an extremely picky eater. This happens more often than not with my younger athletes, but I'm not eating enough vegetables. My mom and dad think I need to eat more vegetables because I know they're important for me to be strong for my basketball, but I don't like them. So sometimes it's even setting goals and having them pick out how many bites they're gonna have of a new food each week. So it can run the gamut depending what the need is. So strategies to meet sports nutrition goals. There are a lot of them out there. And again, it's very unique to the athlete themselves. But kind of how I approach it is I break it down first about the biggies, energy and nutrient needs, and where we can find those. So this is always, I tell the athletes, this is not supposed to be a scary slide. This is supposed to be just a very general kind of where you get your energy from and why is this important. I said this is kind of the nerdy Mary slide, right? And so you can see here that there are only 3 nutrients, not foods, but nutrients that we can get energy from. And that's why you hear, especially your older athletes might be like, should I be following my macros? And you're like, do you know what macros are? And what that means. And so macros referring to macronutrients are those nutrients we need the most of or the largest amount in what we're eating. And so macronutrients, again, that are gonna provide us energy are carbohydrates, protein, and food. So they all provide energy. Vitamins and minerals, although very important in a different way, not for energy purposes. They're for a different purpose. So this is where we get our energy. So I have them kind of practice, how do you identify foods that have energy in them? Hey, first of all, how do you then identify foods that have that might be more carbohydrate rich versus protein rich versus fat rich? When would we, eat more or less of these foods around your different activities? All right, so going through that, and this works well one-on-one in clinic, like I have a more limited amount of time, but when I do team talks or I'm working with clubs, I put these up and have the athletes engage in telling me which foods that they eat, which foods they think of that first comes to mind, so that they can start to practice. It's the same kind of similar approach for our inpatient that may have been just recently diagnosed with type 1 diabetes, and they're identifying foods that might raise or lower their blood sugar, identifying the foods because that's what they're going to eat and that's what they make their choices on. So carbohydrate-rich foods, I think for many of us in this audience, we know, but things that come up often that athletes don't think about is fruit. The most common one is, grains. Everyone's like grains, pasta, breads, but fruit is a big one that people forget about. It's also the most normally most acceptable because it tastes good. Lactose, so the milk, sugar, and dairy you can get carbohydrate-rich sources from, are starchy vegetables. We talk about, different times of year, more produce is going to be available. So right now in the winter months, coming into the spring, wrapping up those starchy winter veggies, beans, legumes. And then we talk about things like, well, what about like honey? Can we get them from other sources that might be considered like not healthy? And we talk about all of the different types of foods and where they might be getting them in their diet. Okay, this is the same for protein-rich foods, but I start to highlight out that you can get a lot of 2-for-1s or 3-for-1s here. So you don't need to eat just foods for carbohydrate-rich intake, just foods for protein, or just foods for fat. That you can really take a look at the whole diet to say like, oh, hey, that glass of milk that you're having or that apple and peanut butter has protein, carbohydrates, and fat in it. You're hitting all 3 of your macronutrients there. So again, they start to see the bigger picture of like, oh, if I eat a variety of different foods, I'm meeting those energy needs, and then we'll dive into the vitamins and minerals. So anyhow, so these are some of the visuals that I might use when discussing those. And then finally, other strategies that come up, fluids, again, I mentioned this earlier, is a big one. I get a lot of questions around, my team gives out sports drinks, should I have it, should I not? What's the type of sports drink? When is one appropriate, when is one not? What about, other ideas for foods and recipes? I think probably by far this is the biggest question I get is, we're out of ideas. What ideas do you have? Do you have recipes? Do you have cookbooks? Do you just have an idea for quick snacks that are okay? Is one granola bar the same as another? Should I be doing a protein bar? What have you? So we talk a lot about different ideas for what might be appropriate for that type of athletics, what's going on in terms of the day and such. In the bag, suggestions are a big one, especially with helping to support our athletes and their individual ownership. What can they pack to put in their bag? Especially if they're leaving the house at 7:30 and they have their sports bag, their backpack, what have you. There are obviously some foods that handle a lot better than others. PB&J, amazing food, does not handle well if the jelly gets all over the place. Bananas, also great, but always take up, everything tastes and smells like banana when it's all together. So we talk about just some tips and tricks for that as well. And then on the road, a lot of our athletes have outside competitions. They are, traveling, sometimes far, sometimes near. How to pre-plan to still be able to meet their sports nutrition goals when they are on the road, especially if some of the food options are limited, or limited in the fact that it's not foods that they are used to eating. So with that being said, that wraps up my talk today. So hopefully when leaving, my take-home messages for you all is that it's really important to assess the diet and dietary patterns as a whole, not just around the sport itself, but looking at the whole picture of the day and how that might impact their nutrition as well as their need for performance and healing. Aiming to have your athlete balance their energy consumption with their physical activity level. Encouraging the athlete to consume nutrient-rich items to promote general health and support any recovery and healing. And finally, really utilizing that individual approach for athletes that have specific nutrition needs. And then that being said, I think I have a couple minutes if people have questions, or are we waiting? What was that? Panel. That's what I thought. Okay, sorry. So I think I might be a few minutes early. So thank you again for letting me come and speak today, and I look forward to joining you all for the panel.
Thank you, Dr. Lesser. All right, we're moving right along here. Next up, we have a 2-for-1 special. We have Darby Swain. She graduated from Samuel Merritt University in 2020 with her doctorate in physical therapy and is working at the Sports Medicine Center for Young Athletes here in Walnut Creek and then also in San Ramon. She recently received her orthopedic clinical specialist and is also part of the sports medicine concussion team. She enjoys treating all types of patients, but has a particular interest in patients that have suffered concussions and soccer-specific patients. We also have Alyssa Bolt. She's an athletic trainer at UCSF PlaySafe program and is the head athletic trainer at Balboa High School and San Francisco International High School. Alyssa earned her bachelor's at San Diego State University and completed her master's at the University of Michigan. She enjoys teaching and practicing yoga, is committed to enhancing the well-being of youth populations through movement medicine. Welcome, Darby and Alyssa.
Hi everybody, my name is Darby Swain and I'm going to be talking to you guys today about strength and conditioning for the female athlete. I do not have any financial disclosures related to this presentation, and here are my objectives that I'm hoping you guys get by the end of this talk. So when we think about the female athlete, we know that over the past 40 years, the number of girls and women participating in sports across all levels has boomed, and a lot of this was due to the enactment of Title IX in 1972. 71-72, there were over 3.6 million boys participating in high school varsity sports compared to only about 300,000 girls. But after the enactment of Title IX by 2018-2019, the number of girls participating had risen to 3.4 million. We saw similar trends occurring at the collegiate level too, with a sharp increase in female athlete participation. And in 2024, the Paris Olympics was the first to reach a 50-50 split, making it the first gender equal Olympics in history. So female athletes are on the rise in terms of their participation, so we need to understand how we can strength train these individuals to optimize their rehab results. So when we think about the physiological differences between a male and a female athlete, we know that female athletes in general have a higher relative strength increase, specifically in upper body muscle groups, and specifically in the earlier phases of strength and conditioning training, versus males have an absolute strength increase that's higher than their female counterparts. Females will have a higher prevalence of slow twitch type 1 muscle fibers, which will allow them to have this potential for increased endurance capacity, while males have a higher prevalence of fast twitch type 2. Hormonally, and this is where we're going to spend a lot of time talking about today, we know that males have increased testosterone, which they theorize can lead to that more type 2 muscle fiber development with increased potential for strength and power, versus females have estrogen and progesterone that can cycle and increase and decrease around a menstrual cycle, which we'll dive into next. And then finally, female athletes have increased lipid utilization during exercise versus males have more carbohydrate utilization. So looking at estrogen and progesterone and their roles in strength and conditioning, we know that estrogen promotes carbohydrate breakdown through glucose uptake and hepatoglycogenolysis, while promoting fat use and sparing our glycogen stores. So overall, it has this neuroexcitatory effect that can lead to improved strength and power outcomes. Progesterone kind of has more of the opposite effect. So it is a muscle relaxant that can negatively affect muscle contractile forces. Higher levels can promote protein breakdown and reduces muscle strength and protein synthesis, and it has a neuroinhibitory effect that results in negative relationships with strength and power outcomes. And then within the menstrual cycle, we know that these hormones fluctuate. So this leads to the discussion of, is there potential for greater strength and power outcomes in different phases of a female's menstrual cycle? So when we look at the early and late follicular phases, we know that this is where progesterone remains relatively low and our estrogen levels peak. So this has the potential for greater strength and power outcomes in this phase. As we transition into the ovulatory phase, we have an increase in testosterone production, which could lead to improved neural activation, muscle contractile properties, and motor system functions. And then as we get into the late luteal phase, we know that it kind of flips, and we have estrogen that is lower, progesterone is higher, and the potential for lower strength outcomes overall. So this is, in theory, what is happening during the cycle. So I wanted to look, well, what does the research say? And there was a narrative review that came out, I think in 2022, that really looked at the impact of the menstrual cycle on both objectively measured performances with aerobic, muscular, and anaerobic training, as well as perceived performance, which we'll talk about next. So in both the aerobic and the anaerobic realms, it was kind of a mixed bag, trending more towards the direction of that there isn't much of an impact. So 14 of the studies that focused on the aerobic component showed that the menstrual cycle phase had no effect on continuous endurance performance, with a few having potentially greater ability to perform an intermittent endurance tests in the follicular phase. Anaerobic, we saw a similar trend as well, with most of them citing that there was no effect. One had some, but again, it was more related to perceived performance. But the area that we can have the potential for the greatest impact on developing our strength and conditioning programs is going to be in the muscular strength realm. So this was the area that was most likely to be impacted by a menstrual cycle phase, again, via those estrogen and progesterone concentrations. So they recommend that strength training can have its best results in both the early and late follicular phase when estrogen is peaking. Again, it was a mixed bag with a few studies showing that there was no difference in phase, but muscular strength is the area where there's the most amount of positive research for this concept. And then they finished talking about impact of menstrual cycle on perceived performance. So how an athlete is feeling when they're in a different part of their cycle based on their fatigue level, pain level, discomfort can impact how they're going to perform with your strength and conditioning program or on strength and conditioning tests. So 50 to 71% of women reported feeling that their performance in training and competition was impaired in certain menstrual cycle phases. And it was best in all phases except, again, for that early follicular and late luteal phases. So perceived performance can be just as important, if not more, than some of these objective measures. So what is the overall impact? It was mixed. 20 of the 35 relevant studies concluded that the menstrual cycle did not produce significant improvements and impairments, but like I previously mentioned, the area that did have the most positive results was in the strength phase, or the strength aspect of strength and conditioning. In studies that did show an effect, performance outcomes were relatively reduced in the late luteal phase more than any other phase, and there's a better opportunity for strength gains in the earlier half of the cycle. Perceived performance can be just as powerful and influential than objective measures and should be considered when structuring training. But as I was going about putting together this talk, the most overwhelming thing that I found was that we have very little research out there on the female body and how these factors can impact our ability to properly strength train and rehab our athletes. So we need more research in this area if we're going to properly work with these individuals. So now that we understand that there is some potential for biasing certain aspects of our strength and conditioning programs around the cycle, I did want to take a minute and just look at, well, when we do strength train our athletes, how does a woman's body respond versus a male's body? And I found this great systematic review that looked at sex differences in resistance training. It compiled about 50 studies altogether that really showed that there is no difference. When we ultimately go out there and we appropriately load our female athletes, they respond in a similar way than our male athletes do. So there was no significant difference in muscle hypertrophy between males and females. And in fact, there was a significant effect favoring females with regards to increases in upper body strength versus male counterparts. Lower body, it was about the same, but in summary, resistance training has similar, if not greater effects in certain areas in women versus men respectively, and both males and females can considerably increase muscle strength and size with proper resistance training. And again, this was the first meta-analysis completed on sex differences and their response to resistance training, and this was published 2 or 3 years ago, so we need more research. Finally, I wanted to touch a little bit on common injuries affecting the female athlete and particular strength and conditioning programs that we can utilize with these athletes for injury prevention. So as a lot of us know, ACL ruptures disproportionately affect our women athletes more than our males. We also have other things like patellofemoral injury, ankle sprains, shoulder instability, and overuse that can also be impacted more greatly in a female than a male, but we're going to focus a little bit more on ACL ruptures. There are a variety of different reasons as to why this happens. We could probably do a whole discussion on this, but just briefly, hormonally, there is an impact, or the hormones of a female can impact the strength and elasticity of the ligaments. Anatomically, there's the pelvis and Q angle differences, muscle strength. We have a greater quad to hamstring ratio and balance. And biomechanics, there's an increased likelihood for females to land in a valgus position. So what is our role in all of this as physical therapists and strength and conditioning specialists? We need to understand how we can go out and impact these athletes in terms of injury prevention. So in 2023, there was a clinical practice guideline titled Exercise-Based Knee and Anterior Cruciate Ligament Injury Prevention, with the overwhelming sentiment being that there is A-level evidence, which is the highest level in a clinical practice guideline, that we should be providing exercise-based knee injury prevention programs for athletes at higher risk for ACL injuries, which are our female athletes. What did this clinical practice guideline outline? When we are developing these programs, we want to make sure that they have a combination of strength, plyometric, and proximal control. And all of the programs that we'll go over next have some combination of all of those things. We need to be doing these programs multiple times per week in sessions lasting longer than about 20 minutes. We want to start preseason and continue throughout the regular season, and we want to ensure high compliance, particularly in our female athletes, specifically in ages 12 to 25 years old in high-risk sports, which they defined as soccer, lacrosse, basketball, volleyball. So really important that we're ensuring compliance in our high-risk athletes. The first program that they talked about, which I think a lot of us have probably heard of before, is the FIFA 11+. It's one of the most highly researched ACL injury programs out there, with the first kind of phase being just a general running warm-up, and then progressing into phase 2, which is kind of the bread and butter of the FIFA 11+. This is the strength, plyometrics, and balance phase. And the great kind of part of this specific program is it divides it into 3 different levels. So there's level 1, level 2, level 3. So it's really customizable to the athlete that you have in front of you. If you have somebody that's younger, that doesn't move quite as well, we don't have as much time for dedicated supervision, we might be starting more in the level 1 aspect. But if we're working with a higher level athlete, high school, college, we can progress into level 2 and level 3. In the strength and conditioning, or the strength component, of all of these programs, they target major muscle groups, including the core, quads, hamstrings, and calf. And then they progress eventually into both double leg and single leg plyometric exercises. And then the FIFA 11+ wraps with some more running exercises, but focused more kind of on agility. So planting and cutting, running and bounding, running across the pitch. And like I previously mentioned, there are multiple studies out there that really show that there's a significant reduction in injuries in female athletes if this program is appropriately applied. The clinical practice guideline also outlined the PEP program, a little bit less detailed than the FIFA 11+ and the sports metric that we'll go into next, but similar components where we have some sort of dynamic warm-up, moving into strength, plyometrics, and agility. This is the only program that really talks about more static stretching after they finish their training session, so targeting all of the major muscle groups in the legs, the calf, quad, hip flexor, hamstring, and adductor. And then finally, they touch on the sports metric program. We use a lot of sports metric components in both our ACL rehab and prehab at our clinic here. And just like the FIFA 11+, they divide it into 3 different intensities. So low intensity, medium intensity, and high intensity days. So it's really customizable for the athlete in front of you, starting with some sort of dynamic warm-up. And then they move more into their plyometric phase next, so double leg and single leg impact activities. I think the sports metric program increases the challenge with plyometric activities a lot quicker than some of the other programs do. So if you have a higher level athlete, this might be a more appropriate program for them. And then component 3, again, is the strength phase. So working on all the major muscles in the leg and the core in both double leg and single leg exercises. And then wrapping up with agility. The sports metric program recommends that we use components 1 through 4, so all of the components when we're in this preseason phase. But as we transition to in-season, we remove a lot of the heavier strength stuff and just focus more on plyometrics, agility, and good warm-ups. They recommend that we perform low-intensity days on game days. And again, we can progress and regress intensity levels depending on the age, skill, and movement quality of the athlete. So in summary, the number of women participating in sports is on the rise. Studies show that there may be some impact from a female's menstrual cycle on strength and conditioning principles, and we should be considering this when developing our programs. ACL injuries are one of the most common injuries we see in the female athlete, but there are a variety of high quality, highly researched strength and conditioning injury prevention programs that we should be utilizing. And like I've said a few times, we need more research on the female body to effectively treat our female athletes. Here are my resources. I unfortunately will not be available for questions today, but if you would like to reach out, please go ahead and send me an email. That will be provided at the end of the conference. Thank you.
Thank you. Hi, everybody. Thanks, Darby, for talking about all those physiological differences between male and female. So now I can just talk about yoga with you all. I'm a yoga instructor, if any of you didn't know. And specifically what I wanted to talk about today is how it can affect our athletic populations, but then do a little bit of talking about how it can gear it towards female athletes as well. I have no disclosures or disclaimers, except for maybe I'm a little biased because I am a yoga teacher. Okay, raise your hand if you've ever done yoga before. Beautiful. Raise your hand if you've ever advised one of your patients or athletes to do yoga. Okay, wow. So I'm preaching to the crowd here, aren't I? I'll just give a little bit of background first. So yoga was originally founded in 1500 BCE in India. The oldest teachings were in the Vedic scriptures, or the Vedas, and it was a group of mental, physical, spiritual practices and disciplines to help calm, control, and still the mind. And then it was brought to the West in the 1890s by a group of different gurus. There's actually 9 different branches of yoga. Asana is the physical practice that we know today that we've brought to the West that we mainly talk about. That's like the postural and the movement. But things like pranayama, which is breath work, meditation, and there's all sorts of other different mental practices. So yeah. Okay, continuing on. So today in the United States, we focus on the main things, the asanas, pranayama, dhyana, which is meditation. And not only is it helpful in a physical way, but also a mental way. Raise your hand if you've given yoga to a patient for mental well-being. Yeah. So it's more than just the physical practice. It could help with a lot of different things. There's a bunch of different types of yoga. Vinyasa is probably like the more common that you've seen in the West. It's a flow style of yoga where the poses are synchronized with the breath in a continuous rhythmic flow. As you can see this little chart right here, this is Surya Namaskar A, which is Sun Salutation A, going through all the different postures that you will repeat multiple times in the Vinyasa practice. You'll also see this in Iyengar, Ashtanga, and Bikram yoga. Other styles of yoga that you'll see are Hatha, which is like a slower, more gentler form of yoga. You're holding postures for longer, but you'll also kind of see this like repetitive movement. This is less so the one breath, one movement, more so like a slower way of going about it, more so like balancing, opposing. You'll see like more isometric holds through this practice. Yin yoga is what we would call more so a static stretching class. You're holding poses for at least 60 seconds long. So this may not be appropriate for some populations, but if you're trying to get some real muscle lengthening, you'll see that as well. And there's also aerial yoga, restorative, and then acro yoga too. Okay, so these are some of the general studies that I've seen in like the athletic population talking about how it can affect delayed onset muscle soreness, which we'll see a lot of our athletes deal with, as well as addressing flexibility and balance. One of the studies that I looked at was 10 weeks of yoga practice. This was actually only males, college-age athletes. They did 10 weeks of yoga bi-weekly, and it actually showed some gains in flexibility and balance. We also looked at perceived, so Darby talked about this too in her talk as well, but perceived performance. There was a study about distance runners and doing yoga prior to an event and how they perceived their performance and readiness prior to, and that helped some of that population as well. And then also some studies talking about depression and how it can affect. I only have 15 minutes, so I'm kind of gonna, instead of talking about all the little data points, I'll kind of just talk about the summary of some of these studies, specifically on athletes, not just females. It can help manage stress and anxiety. That 10-week study that I talked about helped with flexibility and range of motion. It can also help with balance and proprioception, help relieve pain in areas that you're finding tightness, as well as regulate sleep, improve muscular strength if you're doing something like a vinyasa or a hatha where you're doing isometric and repetitive motions, and then can also help with blood pressure and diabetes and obesity. One thing that I wanted to really focus on was athletic recovery. When an athlete comes to you and they're experiencing, delayed onset muscle soreness, a lot of like the fad things that you hear about them doing are like ice baths and like using like the Normatec like leg boots and things like that. But really what the literature shows is the best thing that they can do is active recovery and actually sleep and eat. And so yoga can be like a mechanism of getting that active recovery. I also say like biking, walking, that's good too. But this is a great way for them to do a lower impact, slower activity that's actually gonna help with their DOM symptoms and also help with their mental readiness as well before they go on to their next athletic event. So like I said earlier, it can help with muscle tightness, brings blood flow and encourage lymphatic movement since they're actually actively contracting and relaxing their muscles, improve cardiovascular performance, and enhance their state of relaxation. Okay, this one is now geared a little bit more towards females in the athletic population. So one of the main things that Darby talked about was menstrual cycle and how the hormones fluctuate throughout their whole cycle. And specifically for women, a couple of the studies that I looked at talk about menstrual pain and how yoga was actually beneficial for menstrual pain. One of the studies that I looked at was a randomized crossover pilot trial on daily mindfulness yoga practice on menstrual cycle symptoms and measuring their well-being. Another one was yoga on menstrual pain, physical fitness, and quality of life in young women with primary dysmenorrhea. So the first one, it showed that it was statistically significant that yoga helped decrease bloating, low back pain, menstrual cramps, and stress for women during their menstrual cycle. It was 20 women, and all they had to do was 10 minutes of yoga every day for 2 weeks, or during that period of time that they were experiencing their symptoms, and that was helpful for them. In the other study, it was women 18 to 22 years. It was 34 volunteers, and it was a 12-week study period. They did yoga for 30 minutes every single day, or not every single day, 30 minutes per day, twice a week. And it showed that they had a significant improvement in menstrual pain, physical fitness, and quality of life compared to the control group. So this may have been a study that showed that adding yoga into the lifestyle of women with primary dysmenorrhea could be helpful. The other two studies talk about depression and how mindfulness can affect people as well. Those studies also showed it was statistically significant that mindfulness practices reduced stress and anxiety and improved athletes' sport performance. Okay, so how this applies to women, like I said earlier, 70 to 90% of women experience menstrual discomfort. 62% of women say their menstrual symptom pain is severe, and 10.3% of women experience major depression in a given year. 35% of female athletes struggle with mental health struggles. So this is the patient population that we're taking care of, young female athletes. And this is a tool that we can give them to help with their symptoms. That's not just medication or just deal with it. Okay, so some of my takeaways. Yoga is beneficial not only in the physical, but mental well-being of female athletes prior to or post-competition. It can help reduce menstrual symptoms and increase perceived athletic performance in female athletes. It can easily be supplemented, like one of the studies showed, all you need is 10 minutes every single day and you can make a difference. And even doing a few poses or doing breathing techniques has shown to be beneficial. I do have time for questions if anybody has any. Yeah.
In those studies, did they specify the type of yoga, the focus?
Yeah.
Was it Hatha, Ayana, what's it?
A majority of them were vinyasa.
Vinyasa.
Yeah, so the one breath, one movement flow.
Okay.
Mm-hmm. Yes.
Do you have like a link or recommendations for a 10-minute advice to patients?
Wow. Honestly, if you go on YouTube and you just Google 10-minute yoga flow and look for something that's like the one breath, one movement, I think I'd recommend that. Mm-hmm. Yes.
Sorry.
No.
I often see patients get injured in yoga.
Sure.
Because they are trying to compete with their instructor, trying to do positions that their body cannot do.
Yeah.
So I always tell them it's an individual practice.
Exactly. Mm-hmm.
And don't forget that.
Yeah.
It's individual.
That's so true.
So don't have anybody push you, you have to do what is comfortable for your body, but what do you say as an instructor that they should do?
Yeah, when I am teaching classes, like you are competing against no one except for yourself. Like this is your own practice. Whatever you need for that day, you should do. It's not, oh, I have to do this like really hard balancing posture because I did it last week. Right. It's like meet yourself wherever you are on the mat. You don't have to, there's certain expectations that you have going in, like leave those out the door and do what you can for that day and like what feels good for that day. Because you're not competing against anyone. It's all for yourself.
Are most yoga instructors saying that?
Yes, they should be. But I take a lot of classes too.
They're educated that way.
Yes, and a lot of them they will tell you that this is for yourself and don't look at anybody else around you.
Okay.
It's just for you. Yeah. Anything else? Yeah.
How focused are you on really good proper posture, like specifically the pediatric side?
Yeah.
Ignoring the adults or pediatric side.
Like,
do you have them do yoga in your clinic before you say, hey, go find something online?
So usually so when I'm at the high schools, usually the way that I add yoga into my practice is I'll add it into like a rehab program. And so if they have like back injury and I need them to like mobilize their spine, I'll add in like cat-cows and stuff as part of their program. Or like if I know they're dealing with like performance anxiety, like before races or something, I'll like teach them a breathing technique. Usually I'm kind of doing like more so like little chunks in that population, less so telling my pediatric population to go and do like yoga classes. Yeah. All right. Okay. Well, thanks everybody. That's it.
Thank you, Alyssa. All right, our last speaker of the morning is Dr. Nick Haramiya. Dr. Nick is a specialist in primary care sports medicine. He has particular interests in diagnostic and interventional ultrasound, preventative medicine, and exercise as medicine. Dr. Haramiya earned his medical degree from Western University of Health Sciences and then completed a residency in family medicine at Stanford Healthcare, serving as chief resident and completing the faculty development track. And then at UCLA, he completed a fellowship in primary care sports medicine. He's also the team physician for the Oakland Roots. Dr. Nick.
Nick's got an online poll, so we're going to put his computer on here. Just one sec.
All right. Well, thanks everyone for being patient with my neediness and technical demands, I guess. I wanted to try to make this as interactive as possible. That led to you all hopefully getting a good stretch break or maybe practicing some yoga after Alyssa's talk. Really happy to be here. Thanks for the invitation. We're going to shift gears quite dramatically from some of the morning sessions and going to be talking about dermatologic conditions in athletes. And as a primary care sports medicine physician, when I work with athletes in the training room or on the sidelines, while I do see quite a bit of musculoskeletal injuries, I surprisingly see quite a bit of derm things as well too. And so hopefully this will be useful for all of you that see athletes. I have no relevant disclosures, but I do want to acknowledge Dr. Josh Goldman, who's my colleague at UCLA, who allowed me to use and adapt some of his slides from his talk, which he likes to call the itchies and scratchies. So we will go ahead and proceed. As I mentioned, I wanted to try to make this as interactive as possible, and so I'm going to be using this platform called Poll Everywhere. So if you don't mind taking out your smartphone, or if you have a computer, you can go ahead and scan that QR code or send a text message to the number there or go to that link. You don't have to download an app or anything. I don't know if they're going to steal your information, hopefully not, but give you all some time. Looks like you are able to do that. Great. So we will test this out. So I want you all to type in what dermatologic conditions you may have seen in athletes. And I can't see it on my screen, but I'm just going to peek over here. Oh, cool. You can put emojis. That's nice. Oh my gosh, it's going a little crazy now. Okay, but I think I saw ringworm, I saw maybe turf burn, impetigo on there, a whole slew, candida I think I saw on there. So a whole bunch of different things, which is really great. So hopefully we'll be able to talk about a lot of those things that you all put there. So for objectives by the end of this talk, hopefully you'll be able to identify some common dermatologic conditions in athletes, know the different treatment options that are available for these, as well as the return to play guidelines, which I think is the most important and perhaps the most unique thing about working with athletes, thinking about when can they go back to sport and what things need to be done. Before we dive into it, I think it's really important to talk about some background, specifically talking about terminology. I think this is unfortunately becoming a lost art. When I was a medical student, I remember a resident telling me when I was looking at a fracture that you should have the words to be able to describe to somebody what the fracture looks like without looking at the x-ray so that they can visualize what that looks like, right? The same thing is true with rashes, and I think with our clinical documentation before the invention of EMRs, we had to really know our nomenclature to be able to describe what the rash looks like. And so if you were talking to somebody on the phone about it, you could describe it and they could visually kind of, imagine what that looked like. But I think with photos, it's really easy just to take a photo and put it in the chart, so it's becoming kind of a lost art. But thinking about the way the skin lesion looks, and those are some terms there just as a reminder of how you can describe it. You can also describe the color, right? So if you don't know those fancy words or terminologies, just describing what you're seeing in terms of the color can be helpful. Specifically whether there's erythema or redness, or if it's hyperpigmented, so darker, hypopigmented. And then also looking at the morphology, so describing what it looks like. Is it more round and annular? Is it perhaps more net-like and reticular? Or does it follow specific dermatomal patterns, right, or the distribution of it? And then I also think it's important to think about the sport that the athlete or patient is participating in. This is from a review article that's a little older, from 2012, but they looked at all the different skin manifestations in Olympic sports and kind of looked through the literature. And it probably looks really tiny on the screen, but they basically broke it down by sport and then different types of things to think about. So environmental exposures, whether they're outside playing or if they're in water, different things that might be unique to the sport, like cycling, for example. You think about more friction type things that might occur, and then certainly different bacterial or viral etiologies that might be more unique to the individual sports, which we'll dive into in the future. So just, kind of some food for thought. All right, so the first category we're going to talk about are viral infections, and we'll start with a case. So this is a 15-year-old high school wrestler who's coming in with 2 days of a rash on their chest. They have some associated subjective fever, chills, maybe some lymphadenopathy and body aches. Several days prior, they said they felt like their chest had some increased sensitivity, like that their shirt maybe was chafing there, but they didn't really see much. No sick contacts, no recent exposures, no travel, no other people with similar lesions, but they send you a photo or show you something that looks like this. So, using the terminology that we just looked at, to me this looks a little more vesicular, perhaps clustered together, localized to a specific area, maybe a little erythematous base or redness on the bottom. So what criteria must this athlete meet before returning to play? So go ahead and see. So is it A, must be on appropriate medication therapy for at least 120 hours, must have no new lesions in the past 72 hours, no systemic signs or symptoms, can cover the area and then go back to play immediately, or you're okay to go back and play? What do you think? I can't see the responses, and these are tough questions, I recognize, so. Okay, so from what I saw, it looked like and it's multiple, it's select all, so there's multiple right answers here. But a lot of you picked must be on appropriate medication therapy for at least 120 hours, no new lesions in the past 72 hours, no systemic signs or symptoms, and then can cover the area. So this is actually a herpetic lesion, really common to see in contact sports that involve skin-to-skin contact, so wrestling and rugby particularly. The infectious agent usually is herpes simplex virus 1. They will have tingling or itching as a prodrome, but sometimes your athlete may not recognize what that is, and it could be like I described in that clinical case where they may have like increased sensitivity they describe or feel like that chafing sensation. Then they will develop those lesions that can be painful, that are very characteristic with clustered and vesicular, meaning fluid-filled, and have that erythematous base. And then as they progress, they may blister or pop over, and then you get some erosions and crust there. For diagnosis, it's really clinical, but if you really want to, you can do something fancy called a Tank smear. And treatment is really using antivirals. So oral valciclovir is really the first line that we do. And then, thinking about whether this is a recurrent infection, you can adjust your treatment accordingly. And then in some athletes, if they have a lot of outbreaks, you can consider putting them on suppressive therapy, right? So if they have a big meet coming up and they're worried that they're gonna get a lesion and they don't wanna miss that competition, you can certainly put them on a prophylactic dose. So getting to the answer to that question, for return to play, they can't have any systemic signs or symptoms, so like the lymphadenopathy, the fever, chills, or the myalgias. No new lesions can be present for the last 72 hours. They must be firm and have an adherent crust over it. And they have to complete a minimum of 120 hours, that's 5 days of the antiviral therapy. And unfortunately, they cannot cover it to be able to participate, right? So that's important. With some of these, they can, but with herpetic lesions, they cannot cover it. So it has to have that firm crust over it before they're able to return. All right, this is our next viral rash that you're looking at, and I don't know how clearly it shows up there, but what I see here are some small scattered papules, perhaps a little erythematous with some, you'll notice central umbilication, so in the middle it kind of rolls in. Any thoughts, or you can think in your head what this might be? Yeah, great. Molluscum contagiosum. So also can be seen in wrestling. Swimmers can get it as well. You will see it a lot on the torso, but can be present on the face and hands and thighs. They're painless, so they don't really cause much discomfort, but the hallmark sign is those pedunculated lesions, right? So those kind of dimpled lesions with that central clearing. To treat this, you could do cryotherapy, so like using liquid nitrogen over the area. You can curette them. And then there are some other solutions that you can do. And then once you curette them or cryotherapy them, you can cover them and they can return to play. Okay. All right, and how about this? Yeah, I heard plantar wart. Great. So what I see here is the sole of the foot, a little hyperkeratotic. So you can see the skin's kind of built up over that area. It looks very well defined, perhaps plaque or even papules that are there. So this is a plantar wart or a verruca, and it is usually seen in contact activities. You can see it in weightlifters, often on the hands or on the soles of the feet. They can be a little discomforting depending on where they're at and how often the athlete is having any contact or friction over the area. On appearance, as I mentioned, they'll be well defined and have that like plaque or papule type appearance. And then sometimes if you pare it down, you'll see a little pinpoint hemorrhage or a little dark spot in the middle, which is where those capillary beds are that feed that area. And then treatment is you can excise it or pare it down. There's cryotherapy or the liquid nitrogen, and then salicylic acid or a lot of over-the-counter things that they can try. And there's no need to restrict them from play if they have any of those, okay? All right, so now you're experts in the common viral things. We're gonna shift to some bacterial infections. So we'll start with another case. So a 17-year-old lacrosse player is coming with concerns of some pits and dark spots on the soles of their feet over the last several weeks. It does coincide with them playing more lacrosse recently and spending more time in their cleats. They've also noticed some malodor, which they didn't have before. And it is a little uncomfortable, but not super painful, but they do describe a little mild pain. It's not spread anywhere else. They have no lesions in any other locations, no new exposures or no systemic symptoms. And they send you a photo of something that looks like this. So I see on the sole of the foot, maybe some hyperpigmented areas that are scattered. You might not see it well on the screen, but there's actually like little pits or dimples there, okay? So how would you approach treating this? So A, avoid wearing cleats and encourage use of synthetic or socks or moisture wicking materials. Just monitor, no need for specific treatment. Refer to their dermatologist or use topical clindamycin. Again, I know these are really challenging, but. So it looked like a vast majority for A, some for C, which is appropriate if you don't feel like you are able to recognize what that is, and then some for D, I think, which was topical clindamycin. So this I remember learning, and I was like, I'm never ever gonna see this, but I've actually seen it quite often in athletes, more than I would have expected. So this is pitted keratolysis caused by Corynebacterium or the Micrococcus species. What you see is you see maceration on the bottom of the soles, often on the heel, usually when they're exposed to an environment that's more moist and occlusive, right? So they're not really getting that area aired out, so to speak. You see it a lot in closed shoe sports, so thinking about tennis or basketball. I've also seen it a lot in lacrosse players, which is why I gave that case, or soccer players, especially if it's in a more rainy time when they're in those shoes and it's really wet outside. They'll have those discrete pits and then also have some malodor. And often sometimes athletes might be really embarrassed because their feet smell, right? And so they won't want to bring it up. But if you look on the bottom and you see that, you can tell them, hey, it's not your problem and why your feet, you actually have something going on that's causing that, right? So treating this is quite simple. You can use topical clindamycin or erythromycin that they can apply on the bottom, and they can continue doing that for several weeks. And then to prevent this, it's really encouraging them to wear synthetic socks and avoid prolonged occlusion in their athletic shoes. All right, this is the next bacterial dermatologic condition, which I think was a common one on the word cloud there. So for this, I see it's on the chin. You can see some erythema, some yellow honey-colored crusting that's there, and maybe some pustules as well too. So this is impetigo. This is caused by staph, but can also involve strep. You often see it on the head, neck, and can be present on the extremities. It can be scattered, but they'll have focal pain kind of right over that area. In its early stages, it'll just be more erythematous with some pustules, and then once it really blossoms, then you get that more well-defined area where it's kind of contained to with that classic characteristic yellow honey crusting. And for those of you that have young children, you may have also experienced this with them. Treatment is really just topical treatment for this. Topical mupirocin is really the go-to. And for return to play, they have to have been on treatment for at least 72 hours and no new areas for about 48 hours. And this is also one that they cannot cover, so they can't cover it before they're allowed to participate. All right, and then our next one is this photo. So for this, I see some scattered pustules. It looks like that they're pretty localized to where hair follicles are coming out, maybe a little bit of erythema kind of along the skin or the base there. So this is a folliculitis, so an infection or bacterial infection of that hair follicle. We often think of staph as well as strep. It can be related to skin trauma or skin-to-skin contact. See it a lot in basketball or football players. It'll often appear as painful perifollicular pustules with that erythematous base, and sometimes they can have tender or fluctuant nodules as it progresses. And when I was a med student, I was always really confused about what the difference was between a folliculitis, a furuncle, a boil, a carbuncle, an abscess. Like, aren't they all the same thing? And the answer is yes to some degree. It really depends on how deep the infection is and where it is, right? So when you're thinking of like a pimple or a folliculitis, it's really just isolated to the more superficial layers where that hair follicle is. If you go into the deeper spaces, then you're thinking about a furuncle. And if you have a collection of those together, then you get a carbuncle. And if it gets even deeper, then you can think of an abscess. I think it's really important to acknowledge that while staph can be one of the main causes of this, and it can also be resistant to some medications that we used to commonly prescribe. And there was a big increase in the early 2000s, which I think some of you may remember. I think just in terms of hospitalizations from the community spread of this methicillin-resistant Staph aureus, but then also in our training rooms and with athletes, right? We had to be really diligent about cleaning everything, in which we still are. And the recurrence is usually related to colonization. So a lot of us just have Staph aureus as part of our native skin flora, so we're colonized with it. If they do have recurrent infection and it's really problematic for them, they can try doing a decolonization, although that can be quite challenging. And you have to use the mupirocin in their nares pretty frequently, and then you can do a chlorhexidine wash. So it is quite involved. For treatment of this, it really depends on what your suspicion is in terms of how it looks and whether the area that you're in might have a high incidence of MRSA versus not. If you're thinking about like a sensitive Staph aureus, you could try Keflex or cephalexin. And then if you're thinking more of MRSA, then I usually will start with something like Bactrim, or which is the TMP SMX on there. And then if it is an abscess and it's fluctuant and then amenable to an IND or an incision and drainage, then we usually will proceed with that. So using like a scalpel to lance or break the abscess to promote draining. Warm compresses can also be really helpful to try to make sure that if it's really firm, that it gets more fluctuant so that it can drain. As far as return to play, they must have no systemic signs or symptoms. So if they had, fevers or anything associated with that, they cannot have that. No new lesions in 48 hours. If it is like an abscess or something that's draining, they must have no drainage or exudate coming from that. And they have to be on antibiotics for at least 72 hours. And you also cannot cover this for them to go back. In a similar line, some of you may have seen this. This is something that's more, it looks like, contained to the superficial layers of the skin, some erythema, maybe a little more well demarcated in terms of the borders. If you feel it, it might feel a little more warm or hot compared to the opposite side, and sometimes it can even have a little bit of superficial swelling there. This is a cellulitis, and this can be caused by a bunch of different organisms, but we really think of strep or staph. The treatment is similar to what we talked about on the previous slide, so either Keflex or Bactrim, and there's a bunch of other things there. I try not to use Clinda as much just because of the GI upset that it can cause. So I usually start with either Keflex or Bactrim. And then similar in terms of return to play, I usually wait around 72 hours. What's helpful for a cellulitis is if you have like a skin marker or something to trace around the outline, that's really helpful because you can monitor that while they're on their therapy to make sure it's not spreading and it's actually receding back. And athletes usually like doing that. They think it's kind of fun just to trace it and monitor it over time. Okay, now we'll move to fungal infections. Here's another case. 16-year-old high school football player presents with a small red spot that has raised borders on the upper arm. Thought it was dry skin initially, but became more red and increasingly more itchy. It hasn't spread, no other symptoms or no exposures, and then you see something like this. All right. Lots of head nods. Have you seen this? Maybe common. Yes, I'm seeing well-defined annular, so round area of erythema with an area of central clearing with some rolled borders on the side. So when may this athlete return to play? So upon completing a course of topical or oral antifungals, must be on antifungals for at least 72 hours and the lesion must be covered. After the lesion's covered, or cannot return until the rash is fully resolved. All right. It looks like B is the winner right now. So this is tinea corporis, also known as ringworm. You can see it in wrestling, but in that example is a football player. The infectious agent is a trichophyton, and on appearance, you'll really see what that photo showed, right? That well-defined annular area, round area of erythema with some scaling plaque in that central clearing. To diagnose it, it can be clinical, but if you really want to get technical, you can do a little scraping and then look under a microscope with KOH to see if you can see the pseudohyphae there, which is characteristic of a fungal infection. Treatment for this, you can do topicals, and for topicals, there's a whole bunch of things that you can try. To return to play, they have to be on it for at least 72 hours, and you can cover it after too, okay? This is similar, but just in a different location. So this is on the scalp, but has a similar appearance to the one that we saw previously. Just in nature of it being in a different location, this is tinea capitis. So it's still tinea, but that was on the scalp, so it's on the head. And similar appearance, but with the scalp, you'll see sometimes alopecia or an area where the hair isn't growing anymore. Similar diagnosis can be clinical. You can also do the scraping. However, for this, we usually use oral agents only. So the treatment is a little different, whereas we use topical for the skin one. For this, typically we'll use oral agents. Griseofulvin is usually the one that we'll start with. And it's a little longer return to play, so they must be on it for a minimum of 2 weeks before they can return back to playing. And then this is on the bottom of the foot. Some of you may have seen this, quite common. This to me looks like an area of perhaps maceration, but dry, scaly on the inner digits of the toes. So this is tinea pedis. So this is a fungal infection, or athlete's foot we commonly call it. It's caused by trichophyton. You can see that fissuring that's there. It often is quite itchy for them. Treatment for this, you can use topical or oral, but usually topical is the first line, and you don't have to remove from play, so they can continue playing with this and treat it accordingly. All right, I think this is the second to last section. We'll talk about parasitic infections now. So another case, 14-year-old soccer player coming with an itchy rash over the body, Not sure what caused it, but did travel with their family to Minnesota and spent a lot of time swimming in all the different lakes that we know Minnesota has. Started on the legs, didn't spread, and then spread to other parts on the body, and is very itchy, but has no other systemic signs or symptoms, no contacts with similar rash. And then you see something like this. So like scattered areas of erythematous, maybe papules hard to see, or patches if it's more confluent. Maybe there's some excoriations because they said it's really pruritic or itchy. So what are the next best steps in management? You can select all here. So A is topical steroids, B, oral antihistamines, C, isolate until the rash is gone, or D, topical or oral antibiotics. Are pretty good. So B looks like the winner as well as A, so oral antihistamines or topical steroids. So this is called swimmer's itch. I remember another one I learned, I was like, I'm never gonna see it, and I've actually seen it quite often too. The way it actually occurs is a little gross to some people, but it actually is from this larval trematode. So on the diagram there, you can see that it's a parasitic thing, but essentially there's a bunch of different hosts, and we're, as humans, just subjected to the larva getting confused, thinking that we're a host and trying to come and reproduce, and it causes just infectious, or it's not infectious, but really just an allergic reaction more. So that's why it's often really pruritic and can spread over the areas. So they may start with just some mild itching in the beginning and then develop that rash that I showed on the previous slide. The rash can actually continue for about a week, but the treatment is just really conservative. So, trying to control the itching with oral or topical antihistamines or hydrocortisone cream. It's non-communicable, so if they do have this and the history kind of lines up, then you don't have to worry about that spreading. And then usually after a few days when they're on the antihistamine, the rash will start receding and they no longer have itching and they feel a lot better. Okay. All right, how about this? So the picture is a little hard. This is on the knuckle. So I see areas of erythema with maybe some lacy patterns or lines, burrows perhaps. So this is scabies. So this is something that's spread through skin-to-skin contact. You'll see those erythematous papules in those characteristic linear burrows. It's usually in areas such as the inner space of your fingers, can be in the axilla or even in the toes. Usually we'll spare the head and the neck area. They do have lots and lots of itching, but typically that's worse in the evening times. To treat this, they need to do a full body permethrin cream, and then they can wash that off after 8 to 14 hours. You should also treat their close contacts and then decontaminate household things by washing them and then drying them in high heat. For return, they can actually return around 24 hours after treatment, and then you can do a specific prep to look for scabies, although treating and just monitoring clinically sometimes is sufficient. This is the next one. This is in the scalp, so you can see these are nits in the scalp. So this is head lice, which I think we still see quite often in some athletes. Transmitted by direct contact, you'll see those nits in the hair. They may have some inflammatory papules or some little red spots on the scalp itself. If you look a little bit closer, you can remove the nits by using a comb, and then you can also you should launder everything with high heat, similar to how things were with scabies. And then you can use a topical shampoo. They can return after 24 hours of treatment, and then you should reevaluate them to confirm that everything's been removed. Yeah, let's see. That was I don't know, was the video playing on there? Yeah, that was I didn't see it on my screen, but that was a video that I took when I was a resident, and had a lot of time for some reason in clinic and looked under a microscope and thought it was cool, so I've kept it in my slides since then. All right, in the last few minutes we'll wrap up. We'll talk about some non-infectious dermatologic issues. So for this is something that I've seen often as well. You can look at that. It looks like an area of hyperpigmentation that's pretty well confined on the sole of the foot. You can often see it on the heel as well. This is talon noir, also known as black heel. It's in athletes that do lots of sports that do stopping and starting a lot, so lots of friction. I had this when I was younger when I played soccer. It was on the back of my heel and I was freaked out what it was. But really what happens is you get a little bit of hemorrhaging underneath that area, and it can present in that way. To really diagnose it, if you're eager, you can do like a skin scraping and then look for occult blood, and that'll be positive, but rarely do we do that. One important thing though is to make sure you know your A, B, C, D, E's of melanoma and whether or not you're concerned about that, but it's often mistaken for that. So that's where your history really comes into play and thinking about the location of it. And this you can just monitor, no need to really intervene unless it's causing a big issue. And then this is quite common, I think, for all of our athletes, blister that's there from repetitive friction, thinking about what equipment they're using or ways that they can modify their activities to prevent this from happening can be one thing that you can do. Some prophylactic things is also thinking about how they're breaking in new shoes. You can use lots of things to cover the area, like second skin or new skin is quite common in training room settings, but moleskin can be another option for you. All right, so we made it. So in summary, these were all the different conditions that we actually talked through. I think these are some of the more common ones that I see on a day-to-day basis with athletes, and then also, honestly, just with family and friends sending random photos of rashes and who knows what location that you can't make out on the picture. I will draw your attention to some resources. So in California, the California Interscholastic Federation has a skin form, so any athlete that has a rash, their provider can fill this out, and then you document where the rash is. They also have some guidelines. I will say that the guidelines for high school, NCAA, and all different leagues are very different, and so looking at what organization the athlete is playing for and following those guidelines will really be your go-to. But the CIF has a bunch of different common things that are listed and how they recommend treating it and the recommended return protocol. For the NCAA, they also have a skin form. You'll notice it looks exactly the same to the high school one, except I think when you get in college, you grow hair right on there. But otherwise, they have the same thing where they list everything out. And then I'll draw your attention to the NFHS consensus guideline. That's a really great resource too to take a look at if you want to just reference something from this talk and you're like, I don't really remember. That's another thing that you can take a look at. Those are my references, and then I think we're just on time for questions. And then Come Watch the Roots are our home openers today at the Coliseum, so excited for that. So go Roots. Thank you all.
Sure. Thank you, Dr. Hadamiya. If we could get the morning panel presenters to come up for questions. Dr. Hadamiya will not be taking individual dermatological questions at this time, but everything else is fair game.
Hello, my question's for Dr. Lesser. Hi.
We'll do yours, sir.
In my office, we have I see pediatric orthopedics, but we have a lot of patients following a fracture where the parents are asking, are there any supplements they should be taking? A lot of them are obviously just injury prone, but is there something you would recommend to supplementally add to their diet that could be preventative or helpful?
That's a great question. So more often than not, they likely don't need a supplement, but it's really from you or whoever, if you refer them out to a dietitian, to take a look at what they're eating to see if they're actually meeting their needs. For fractures in particular, we just look at bone health nutrients. If you feel that, and this from your own assessment, that perhaps their diet is limited or it's not varied enough that would hit some of those key food sources for those nutrients, or you're concerned about, let's say, a vitamin D level or something, knowing that a lot of the food sources are pretty limited in vitamin D, you could check their vitamin D and see if a supplement was needed. But more often than not, no. Oftentimes I have families that come in and just say that they are concerned that day to day their athletes aren't eating enough, and so can they take a multivitamin? Is it safe? And it is safe, especially most of them that are out there now. If you are concerned with the type that they are taking, they can always do some label reading around it, but nothing in particular that they would need to take extra, only if it seems like they're deficient to start with. It's a good question, though. I get that one all the time.
Yeah. I just, like, they shouldn't, but I guess, okay, thank you.
They don't need it. It doesn't hurt, though, but more often than not, they're probably fine with what they're eating.
Excuse me. This question is for Dr. Hadamiya. So in your slides, you said that for tinea pedis, there's no real return to play policy for that. I'm assuming that's more for sports that have, like, where you typically wear shoes. I was trying to look to see if there was any policy for, barefoot sports like jiu-jitsu or judo. Off the top of your head, if there's any, recommendations for that, just so somebody doesn't get athlete's foot in their face or anything like that.
Yeah, thanks for the question, Dr. Chung. I unfortunately don't know of any guidelines for that. A lot of the stuff that I presented was based off the high school guidelines, and I think there's certainly a need to look into the other sports that are barefoot. I know that you're big into martial arts as well, and I definitely wouldn't want athlete's foot in my face either. So I think that, I don't have an answer for that. I think perhaps the individual organizations may. That's where there's still a lot of gray area with that. But if you find out, you can always let me know too.
I'll do some more research then.
Hi, I also have a question for Dr. Lesser. Would you be able to give us your spiel about creatine for teen athletes?
I wouldn't necessarily say I have a spiel for creatine. I mean, the big thing is that in many sports, particularly youth athletics, dietary supplements are a no-no, especially because they're not regulated at the same amount as, let's say, medications and such. So there's more of a concern of the safety and actually what's being provided. I will say with creatine, it is the most widely studied, and so there is actual more evidence compared to others. But my stance is that no one in youth athletics should be using any sort of performance enhancing. And there've also been more like I don't want to say crackdown, but there's been more like structure in drug testing. And so I've had some swim teams particularly that I've come in and actually give talks with about this because there is concern that some of the athletes have heard things and they are trying to take supplements. But in terms of going back to your question for creatine, if I have an athlete that asks me specific questions about creatine, a lot of the times it's about, well, why would you like to take it? Like, why are you being told or what have you? And also the research that's out there is also very sport specific. It's not widespread in terms of all athletes for this. So it is, my first, I guess, spiel would be it's likely not needed, and I would be more concerned with safety around the use of it, and I don't recommend it. But if I have athletes that are going to continue to use it and they want to learn more about it, we'll have a conversation about the why and when and what the evidence says in terms of if you would use it. It's very rare that I get a question, and if it is, it's somebody that's looking to go on to collegiate athletics, and so it's also a conversation that if I'm in touch with their sports dietitian there, why the need for it. So, but I recommend against it. I get people that ask about certain protein supplements too, and if they need it as well. And I just say in general, we don't need any sort of performance enhancing, and it's for the American Academy of Nutrition and Dietetics and for the Pediatric Association, it's recommended against any performance enhancing supplement in youth athletics. Does that answer your question?
I guess it's for people to ask, what are what's the policy, what's the safety?
I mean, some of it is a basic of, if you're not even thinking toxicology, it's just how is it formulated and is it actually creatine? We don't know. We can talk and give education around how would you do a kind of more thorough search to vet out whether or not you feel comfortable about any supplement you might be taking, but also if it's laced with something. I mean, and I think that is where some of these coaches that when I come and give clinics and such that they want a couple lines on is that you don't know if you don't know where you're getting it from, and it might come up on a random drug test that something else was in there and you just aren't even aware of it, even if you think that you're taking it safely and such. So it's not, in my experience, I haven't had an athlete yet that's really needed it. They were more just kind of curious because they saw it and they were like, do I need this? And after talking them through why or when you would use it, they realized okay, I don't actually really need this. So But I know it does come up and more. They see these things on social media and they think that they do need them. And so it's more about having the conversation. That's a great question because it comes up.
Just to kind of expand on the nutritional supplement questions. So collagen is becoming more and more popular. So I totally get it. You should eat natural foods, get all your nutrition from there. Like every nutritionist says that, which I totally agree with 100%. What about for like soft tissue and bone healing, using collagen to supplement a very good holistic whole food diet?
That's a great question. So I think just because I'm also a pretty big research nerd, like going back to the literature and even thinking about in the context of who your patient population is. So personally, what's very challenging about sports nutrition and youth athletics is that although there is now a little bit more, there's not very much research out there in terms of the nutrition except for very sports specific, and oftentimes it's the older athlete, like 18 years old. So that is like the tail end of the athletes that I normally work with. So could there be potentially some benefit? Possibly. Also taking a look at the form and how much is kind of the key thing. Oftentimes too, the families that I work with don't have the means to be purchasing supplements, and supplements that might be of higher quality. Again, it kind of depends on where they're coming from. And some of the forms that come out in these supplements, like where you actually see the possible benefit in whatever the research context, animal, human model, what have you, are oftentimes in amounts that like we wouldn't just normally eat. And so again, it just kind of is like what is the context, and like would that actually be beneficial? And first and foremost, not just almost like eating, you can eat everything to eat first, like more of the issues that I see in my athletes is that they're just not eating enough, or they're not eating enough of those foods. So if we tease through that first, and then they're consistently showing me like, okay, here's what I'm eating. I'm constantly meeting my needs. I'm constantly consuming the nutrients that I know will help with healing. Like, could we try it out like in a safe way? Possibly. I've probably had maybe one athlete where like we've really like gone down that path of like, I've tried all these different things. Like, can I try adding this extra vitamin C or whatever, a single nutrient in to see if it helps anymore. But so I don't know if that fully answers your question. I think it really is more of in the context of the athlete. I don't want to say it's necessarily good or bad, because again, where I struggle is that there's not a lot of places to make that transition from like what's seen in the adult literature to the kids literature, and also knowing enough about like if there's any detrimental effects that's going to impact, like maybe it might help with healing, but is there another like secondary effect depending on what the makeup of the supplement is. But it's a good question because it's something that comes up, especially if you have athletes that are injured and they're frustrated, they want to get back out there, and so they're just trying to do everything that they can to get back out there.
Just a quick follow-up. So do you have a resource that you have or recommend that would provide information on nutritional supplements that actually like is good research based and safe and not like selling products?
Yeah. So I mean, at the NIH, there's the Office of Dietary Supplements, and so they do put out quite a few different fact sheets on there's more out there than what they can publish on, but they compile the research to put together these like quick fact sheets for both professionals as well as like the regular day consumer, just to understand what are the claims and where that's coming from and where the research is based for that. It's been a bit since I've had to use it, but Kaiser also used to have like a really nice database that put together some patient education materials and also some for professional use as well. You can always go to the NCAM site too, or the kind of the top 3 that we use. And actually for my classes at Berkeley, we use them as tools for them to integrate into their training to practice going through that. Going through like if they were approached in a patient situation, no matter what, not just sports nutrition, on how you would navigate those conversations and provide additional resources. Yeah, it's like the National Academy of Complementary and Alternative Medicine. That's a very broad one, but you can find dietary supplements and like nutraceuticals. And then if for some reason you're working with other like dietitians or nutrition healthcare professionals, if they're a part of the academy, they have like the functional foods groups and such, and some individuals there would have more of a background about using like what the other resources they put together through their publications. Sometimes it requires a membership though, but those would be kind of my top 3 big ones that are more widely available. Great question.
Okay, one more question for the panel.
It's also for Dr. Lesser. What are your thoughts on 2 separate things, caffeine use for enhancement, and then also just non-sugary, like electrolyte-based kind of focus drinks?
So we'll tackle caffeine use first. Again, any sort of like performance enhancing in youth athletics, like in the younger athletes, for sure, no. And definitely for the older athletes, usually it's the kind of the conversation about the why or what have you. However, I do have athletes that are getting into those older years that are competing like in cross country and such, and they're like, hey, I use goos, gels, what have you, which are fine and safe, but some of them do have caffeine. What does that look like in terms of my feeling? And so we do have conversations about like when you use it, why you use it. It is, the amount that's given in there is safe, but also it depends on the athlete. Is it somebody that regularly consumes caffeine? Either in coffee, not just the sugary coffee drinks, but like I do have athletes that have been drinking cups of coffee, or they have tea that have caffeine amounts like since they were younger, so their bodies are attuned to having it, whereas some athletes are like, I heard caffeine is good, I want to start using it. And it's like, well, let's talk about like what is your caffeine use right now, because everybody responds differently to caffeine. So again, individual conversation in sport, I wouldn't recommend it. It's usually something that's brought up of like as part of my training, like here's something that I'm thinking about to help because I'm, you know, burning out or whatever. And so I've been trying these gels and I think they work. And can we talk about that more? The electrolytes, you're talking about like just sugar-free electrolyte things like Noon or something like that. Yes, Noon comes up a lot. So again, if you have athletes that are eating and drinking normally, probably hitting their electrolyte basic needs fine, but we do have individual differences in sweating and losses, and this could, you know, run the gamut from if you have somebody who is sick and coming off, or if you have somebody who's a heavy sweater, like myself. I had this conversation yesterday with someone. So then it's about kind of checking in and out with that athlete of like, what's the type of activity and like how much losses they might be having or experiencing. Are they experiencing any sort of hypo or hypernatremia to tease out? Is it fluid? Is it electrolytes? And can they have a Noon tablet or what have you? Probably is okay, but more often than not, they don't need it. And we kind of talk about like just drinking Noon throughout the day is not needed. And if they're drinking a lot of Noon throughout the day, taking a look at how much is in there, we can compile and see like on top of what else you're eating. So, which is why during the assessment, I do a lot of like supplements of any of them so I can compile and be like, we're having a lot of potassium, a lot of sodium, and we can cut back on those things. But if you do have an athlete that's like a heavy sweater, they're a soccer player, what have you, and they're like, you know, actively feeling the salt coming off of their face, it might be fine to have like a tab. It's again very individual, but also compared with what the fluid is to keep that balance. It's a great question though.
All right, thank you to the panelists. We are now taking a 15-minute break and we'll be back at 10:35.
Sorry, wake up. I got it, bro.
That's big creatine.
What?
Big creatine.